scans, which are little portable ones. They're basically like iPads, and you can see it straight on that. But we have this huge day in Castle Fest this week, so all the scans are at the castle right now. So we got this guy.
So how many of you guys have actually used ultrasound before? I know Jeremy, a couple of you all have. Awesome. I assume you sounds like you're all aware that this is actually happening in other EMS services out there, that they're getting more toys basically, which who doesn't want more toys to play with, because it always makes for more fun days. So that's what we're going to discuss here today. Get this off the screen here.
So trauma for us is like very algorithm based. Basically, patient comes in, ABCDs, a whole 9, and then if it's like a blunt trauma versus penetrating trauma, we want to see if this person's bleeding, do they need to go to the OR? So that's where we're at with this.
Yeah. So what we're trying to do is figure out what are some possible ways we can use ultrasound for you out in the field. So first one is what we have called, it's called the EFAST. This is a mnemonic we all use, where you probably hear them asking, hey, was fast positive or negative? This is what we're referring to, the focused assessment of sonography and trauma. And we're looking for a few very basic things on it. We're only trying to answer a couple questions, and that's it. But it does tell us a lot of information. So anytime we have a trauma, as always, as everyone knows, we always start with our clinical exam. That's first and foremost. It still gives you the most amount of information right off the bat. When just looking at a person, you all can tell as much as we can if someone looks
sick, not sick. Yeah.
If they look sick or not sick, right? But then with the ultrasound, we can answer a few specific questions. Is there free fluid in the abdomen somewhere? Is there free fluid around the heart in the pericardial sac? And do they have a pneumothorax? That's really all we're trying to answer. Some very quick things. And even with that, we don't know what that fluid is. Okay, so sometimes that fluid in here in Kentucky is, well, I just got some ascites from the cirrhosis. But it does answer a few questions for us. And then also allows us in the hospital to make some decisions. We make a lot of branch point decisions right off the FAST coming in. Whether or not someone's going to the OR, whether or not they can go to CT scan, how we want to approach their management.
So how is it performed? Basically, we have 3 abdominal views and then a cardiac view. We look at the right upper quadrant, which is our hepatorenal view. You basically look between the liver and the right kidney. Left upper is between the spleen and the left kidney. Pelvic view, you're looking around the bladder. And subxiphoid is right under the rib cage into the heart to look around the pericardium. Now, on like a thin person, it's easy to do that, where you can like flatten it right under. Most of our patients, we can't. So we actually do what we call like a long axis over the heart, but we won't talk about that today. And then we look at both lungs to look for, like I said, a pneumo, or what we call sliding.
So you can see these are the questions. We're looking at the certain spots to answer the certain questions we had. Fluid in the abdomen, those spots, fluid around the heart, and do they have a pneumo? So we look at the lungs. That's exactly why we pick the spots on the body to answer those questions. So we have always a few limitations with this, just like any of the other toys we play with. There's always operator dependency, how much experience they have with it, how much time they've spent with it, how comfortable are they deciding, is it positive or negative, is that fluid, is that significant fluid at that. Also here in Kentucky, body habitus can be a bit limiting as well. Sometimes it's just physically challenging to get the probe into the right space, especially if situations of trauma, and they don't always have the best analgesic to control right away when you're trying to take a look at them. So that can cause some difficulties as well. And as we mentioned before, the fluid can be anything, like we said. We're looking for it to be blood, but you don't know if it's ascites or something else. And then we also have to have a certain minimum amount, of fluid to actually be able to detect. So you can have some bleeding that you're not going to see if it's such a small amount up there. The other issue you have is this is only good for like solid organ injuries that cause bleeding. So if there's bowel injury that have, basically like almost like a whiplash injury to their bowel, and you want to always see that sort of thing. You want to see if there's just injury to hollow organs. And if anything's in the retroperitoneum, you can see back deep behind there. So what we use for this is we have a couple of different options. There's a few different types of probes. This first one is the curvilinear probe. That's really great for like looking into the abdomen on people. It's a greater depth. For lack of better words, you almost can say it doesn't quite have as great as clarity, maybe as one of the linear probes that we use, which is much more useful for superficial structures. But again, we're only trying to answer a very basic question. Is there fluid there or not?
So this is our right upper quadrant view here. Patients laying down, you're basically right out here looking for that spleen, I'm sorry, the liver kidney view. So this is basically what we're looking for. So in ultrasound, muscle is kind of gray. You can have white. Really, really white is usually bone. But anything black is fluid. Again, we don't know if that's blood, ascites, urine, but dark black is fluid. So it's tough on a static image to really differentiate, but we'll go into some practice. So these are the anatomy, liver, kidney. You have some bowel, lung out here. That's basically our right upper quadrant view. So this is kind of normal versus abnormal. You see this kidney kind of hugs right up underneath that liver, nothing really in between except for this like white little kind of capsular space, and then some lung back here. Here you have this kidney, you see liver out here, but there's that black stripe right in between where you don't see that here. That's fluid. In this view, the most common area of fluid that will build up is in between that spleen, the liver and the kidney there. So another picture here, that's a lot of fluid. So you see fluid, black right in here, black here, and all around the liver tip there. So you're seeing lots of fluid. Again, this should be right, snug, nothing between the kidney and the liver. There's some fluid there. Free fluid all the way out here. You see all that black.
And again, this is always in the right clinical context. Patient with cirrhosis, maybe this is not as important.
So what do you guys think? Normal or abnormal? It's okay if you're wrong. But what would you call this one? Just kind of looking at it. You see any obvious black between the liver and the kidney there, or above the liver? Shaking your head, no. So agreed, this is normal. It doesn't really hug completely snug, but this is gray, which is fine. What about this one? Normal. Yeah, so you're seeing a lot of black, lots of fluid in this area here. How about this one? Would you call that? Yeah. So I would call
Now,
that.
would you want that to be, how would you estimate greater than 250?
So that's a good question. We can't.
Yeah.
Again, we're just saying fluid, no fluid. Yeah, but we can't. And you need at least 250. So sometimes you have a GSW victim, they haven't accumulated enough blood. You look and it looks negative, but you just don't have enough fluid at that moment. If you maybe waited 10 more minutes, put it back on, big positive. So it gets static, exam at that moment. But yeah, good question. You can't really know how much fluid's in there. So left upper quadrant, same thing. Just on this side now, you're looking between the spleen and the kidney, and it looks a lot similar, very similar to the other side. So again, looks like liver, but it's actually spleen. On this view though, actually most of the fluid, if it's gonna collect, it's gonna be above the spleen. So a lot of times we can miss that. We usually have patients take a deep breath to push that spleen down so we can kind of look above the spleen. We'll show you. It's a spleen, kidney, very similar to the other view. But you see the fluid now is above over that spleen. Doesn't really collect in between like it did on the liver view. It can, but a lot of times it's above. It's a lot of fluid there on that one. And then the pelvic view, there's two kind of ways we do either transverse. Now we're moving more to this kind of horizontal view. Basically going through, you're going bladder, and then in a female, you'll have uterus underneath. So if you're kind of comparing these two, here's bladder, again, black, so fluid, but this is urine and it's contained, it's like in a little box. And then out here's uterus. So to compare, this is male, so big bladder, contained pocket of fluid. And then you can't really see it in this view, but here's some prostate back here. And then a female, you have bladder, here's the uterus, vaginal.
So we'll be looking for fluid just posterior to that.
Yeah,
It's
so
like the most
we're looking
independent
for-
spot in the body.
Fluid anywhere out here and sometimes even under there. So very difficult to tell on this view sometimes, but you're seeing bladder, you see here's uterus, vaginal canal, and then you have some dark spots behind the uterus there. That's positive. Again, fluid collection or black outside of the box, that's fluid. Positive over here too. All this is positive.
So the next one is the cardiac view that we use. This one we usually can take a subxiphoid approach. It's basically right underneath the xiphoid, kind of flattening out the probe and pushing down. We go and take a look at the heart. And again, we're not really caring, how there's a squeeze, do they have LVH? All we want to know is there a large amount of fluid around the heart that's causing pain but not physiology? So looking here, you can see that's your heart there. And basically, we'll be trying to look in between the space just posterior to the heart, where it's going to be dependent as you're laying down flat. Is there any fluid there? So you can just see the ventricles of the heart, right, left, and atrium, both sides. So this one you can see here. There's the pericardial sac that runs all the way around. You can see the fluid coming up and around. It's actually quite large. The fact that's coming up around the heart. It's not just a little bit dependent fluid in the
And you
base
still
of the
have
heart.
RV, LV, and these are your atrium, but you could still see both ventricles. You still have lots of fluid around. And this one, you have complete collapse of this right ventricle. You don't even see it because there's so much fluid pressing down. That's
Starting to coagulate, yeah. And then the last thing we would look for is we take a look at the lungs again to look to see if there's any signs of pneumothorax. You just look both sides rather quickly. You can go through a lot of the lung fields, but what you're interested in usually is a large pneumothorax. Oftentimes we'll get chest x-rays here, don't see a pneumothorax, and get the CT scan, there's a pneumothorax on there. It's maybe not something that we need to find urgently, but if there's a large one and they're becoming tachycardic and hypotensive, it's something we'd want to know, and maybe something you guys would want to know in the field as well. As you're driving in, the person starts tanking, but you're like, oh, they're not bleeding anywhere. Maybe this would be the time that you guys are thinking about doing like a needle thoracostomy. This would potentially be helpful.
This one I think is great for you guys too, because I can't imagine you guys can hear like breath sounds with like the sirens and like the chaos out there. So if you see lung sliding both, and you're pretty confident that you've got good full lungs there.
So in these here, you can see what we're looking for is the rib spaces will cause shadowing all the way down, because you imagine the ultrasound doesn't penetrate down through the bone. So you see those two long black areas basically where ultrasound probe isn't getting any information back, because it sends off the signal and it bounces back right at the very top. So it has no idea what's below that, so it just blacks it out. That actually wouldn't be fluid in that case.
Yeah, so to look at this, if you go to the next slide, so you look for two ribs, and between the ribs is this white, you can't tell in this picture, but you'll see when we do it, like a shimmery line. These two ribs cause like a shadow effect, but you're looking for this stripe right here, and you're gonna see if it's moving or not moving. So that's what you're looking for. Again, just more views, ribs, and then you see the black rib shadows, and you're looking for that white, this white line.
My apologies. So what we're looking for here is the signs of a pneumothorax. There's a couple different ways to look at it. I think this is one of the more helpful ways. So we look for what's called the lung sliding on exam. So we'll see, when we'll play the video, there'll be, this part here will be shimmering along it. You'll see like little comet tails that we describe them as moving. And you'll see this section right up to here, it's not moving at all. And that's because there's air between the chest wall cavity and the lung. So the friction basically, the lung's not kind of rubbing up against the chest wall like it's supposed to be. Let's see here, we have see.
Sure.
I'll pull it up here.
Yeah, so if you can imagine, if the lungs are inflated like they're not supposed to be, then every time you take a breath, that lung is kind of rubbing on the pleural space. And so when you look on the ultrasound, you should see some friction, some sort of movement. If part of that lung is collapsed, then it's detached from the wall and you won't see any of that movement. So you see that shimmery, normal,
That's what we're looking for to see on the
What's
sliding.
the sensitivity of that as far as diagnostic ability with pneumothorax?
I'm sorry.
What's the sensitivity of ultrasound of the lung?
I think it's like 96
Yeah,
to
it's-
98.
No, it's greater than
X-ray.
I don't know the
exact number.
Yeah. It's much better than X-ray, and you can actually, like he's gonna show you, find what we call the lung point. So you see like this part's not moving at all, and then you can kind of map how big even this pneumothorax is.
So this whole area you can see is not really shimmering like we're supposed to. There's no like comet tails right on the pleural space there.
Yeah, you see the muscles moving because they're probably trying to breathe, but this line here is very static. There's the other one you saw a lot of kind of, they call it a bunch of different things, ants on the line or shimmering, or they call it a bunch of stuff.
Comet tails.
Yeah. Do you have is it lower maybe?
So,
That one with the lung point?
yeah, there's one. So again, this is, you can actually see where, when they have pneumothorax, doesn't mean the entire lung is collapsed off the chest wall. You can see actually where there's normal lung right through here. That's all kind of shimmering. You can see it's kind of shimmering all the way through here. And then this section right over here, look, there's really no shimmering at all. So that'd be a pneumothorax. And again, that'd be helpful in the field if you guys were trying to decide what's causing this patient to decline so quickly. And you said, it's really hard to hear breath sounds sometimes. It can be even harder than trauma bay, even when we're trying to get everyone to be quiet for us. So I found it more helpful than even just trying to listen to lung sounds. And even then chest x-ray, because sometimes chest x-ray can be very difficult to actually see the pneumothorax on. So this is, I think, some of the areas that are relevant potentially for y'all. Certainly it sounds like they may discuss starting like IVs by ultrasound will be one of the things that you guys can look at. But I think these, potentially we activate for all sorts of things now. STEMIs, we call that activation. There could be potential in the future, say, is there some sort of trauma activation or OR activation by this patient is tachycardic, they're super hypotensive, and we got a positive FAST. They don't really need to hang out in other ERs for very long, especially if you guys can know the information ahead of time. They can call along up to the trauma surgery team.
And I think you, Jeremy, talked about like red versus trauma alerts versus alerts. I mean, if you've got even a normal vitals but a positive FAST, you could probably read that and have the surgeons down there right away.
So just kind of doing a cursory review, there are a number of people that have been looking into just pre-hospital ultrasound for differing approaches. So it's out there. Sounds like I didn't even realize it's starting to become more of a thing now in Kentucky, and start looking for different uses for it. Have you all discussed what all are going to be the applications for it? Or?
Well, we talked about EFAST. One, I think the fiscal component is obviously the different probes. So a linear probe is 5. The cheapest you're going to get a linear probe is right around 5. Cheapest you're going to get a curvilinear is going to be 5. And then phased array probes and things of that nature, which can do a little bit more. But we are probably not going to look for it for IV access. It was mostly FAST. And the hopes is that, Chloe, I think, Walt, were they included in the email them that we'd sent out about the meeting?
No, I don't think so.
Okay, because our paramedics have been approved to come into UK and do an ultrasound residency, for lack of a better word, with the ultrasound residents. And so we're just we're working on that right now.
Cool.
You might be seeing them in the ED some.
Awesome.
Well, let's try to look. I think that was our last slide.
Yeah.
Let's look and see if we can.
It'll take a little time if you guys want to come up and give it a try if you haven't used ultrasound before or haven't done a fast exam. If anyone's interested.
And some of the literature I've heard in last year, some of the more progressive places in the nation were using ultrasound as a on traumas, and basically saying if you had no kinetic activity of the heart on scene, you're pretty much done. If you, in many places that are progressive, they'll work a cardiac arrest for a period of time, and if you don't have any kinetic activity for after 20 minutes or 30 minutes, then you're done. And they also did this was North Carolina, Dr. Mill, I believe was his name. They basically did any female of significant mechanism. They got a ultrasound of the abdomen, not to say that you're pregnant by 16 weeks or 20 weeks or anything like that, but is there a fetus there? And if there was a fetus there, they would automatically go to a trauma center. There wasn't going to be a question about it. So that was part of their protocols, but it was related to like battalion chiefs and that kind of special response vehicles that responded to an incident. It wasn't everybody they were trying to train. It was just certain groups of people. So that was what I've seen in the last year about that.
Yeah, and we tend to use it as well, even in our codes and cardiac arrest, because it's super helpful to look for, when you're running through your mind, your H's and T's again, take a look at something else causing this. And like you said, we also look for like the cardiac standstill as well, because it can be sometimes extremely difficult to check for a pulse on patients. We found that literature shows we're not very reliable at finding a pulse either, or estimating blood pressure based off that.
Could you tell me, as far as linear, would you use a linear probe for a lung ultrasound?
Yeah.
Could you use like a phased array?
You could use any of them. You could even use the curvilinear if you increase the depth. I would use either one, whatever you have, but the linear is the most.
That's what some of the stuff we're looking at right now. There's a bunch of systems coming out that are kind of affordable and some that aren't affordable at all.
I tend to personally use the curvilinear for the lung as well, just because it's already in my hand, and I just have a habit of just changing the depth real quick with a couple finger clicks, and then I can get the information I need from that. Because you're only answering a few basic questions. Certainly the linear shows you a better image, but
well, hopefully everything pans out. We should have 8 paramedics in the ED kind of running around with the residents kind of doing non-acute ultrasounds. We'll see how that works.